Good morning, everybody. How y'all doing? Good morning. We're so happy to have y'all here today. And I know this cohort is probably our biggest geographic area. We've got a couple that have a huge part of the state represented. But I know some of y'all traveled pretty far. Some of y'all not so far, but either way, we really appreciate you taking the time to be with us for the next 2 days, taking the time away from your hospitals and your daily lives, your families, your normal routines, to be here together to learn from each other and about some processes and changes that you can make to help make healthcare safer for Texas moms. I'm Julie Stagg. I'm the TexasAIM program lead from Texas Department of State Health Services. And this first session is really just a welcome and introduction. So we'll be introducing our faculty and our leadership, and we also our staff. We also want for you to introduce yourselves. So I'm going to give you a couple of minutes. We would like for you to identify a single member from each hospital team who can introduce your team. You don't need to introduce everybody that's here with you because we'll want to, we've got about 26 teams, so we'll want to not take too long, but we want to hear about your hospital, and then we ask for you to think of what you want to bring to share to this learning session and what you want to be sure to take away from it. So if you can let us know what's your ask and your offer from your hospital team. So in a little bit, we will ask you to come up. I'm going to go through some things, but I'm going to give you just a couple minutes to talk at your table to figure out who's going to represent and then make sure you know your ask and your offer. Okay, does everybody know who's going to come in a little bit? Not yet, but going to come introduce your team. Does anybody need more time? Okay, thanks. Okay, so I want to recognize our TexasAIM team who supports us at every level of our organization to bring TexasAIM programming to hospitals across the state. We're really fortunate today to have Dr. Shuford, Dr. Amanda Hall, Laura Gabbert-Charney, and Shruti Aras Mendez, thank you, here with us, who represent our leadership, including Dr. Shuford is our DSHS commissioner, and Dr. Hall is our associate commissioner of community health improvement. And then Lori and Shruti are leaders within maternal and child health. And then lots of people working behind the scenes, and you will get to meet them in a little bit. We also have a team that works kind of day to day to keep things moving forward. And then a team of including our expert faculty that help plan the content and the information that we're bringing to you. And we do that with a lot of input from y'all. So we're constantly looking at the different information you share with us through your reporting, through your emails, through our time together in these learning sessions or in the community, and then in action period calls. So we really welcome your feedback. Because we're constantly eager to know where you're at, what things y'all are working on, what you need, and that's what our goal is to help support what you need. We have a wonderful group of volunteer faculty that travel across the state to come to these learning sessions, put content together for action period calls. And there's a wealth of expertise in this team, and then also in this room. So I wanted to take a minute to call our faculty and our staff and our team up to the front to introduce themselves so you can see who's here with us over the next 2 days, and you'll and who you can go to with questions and for support. Yeah.
Everybody, I'm Laura Wando. I'm the Maternal and Infant Health Branch Manager at DSHS.
Morning, I'm Carrie Epps. I'm a maternal fetal medicine physician in Houston, and I'm the medical director.
Good morning, I'm Jamie Morgan. I'm MFM at UT Southwestern in Dallas, and I'm the deputy medical director.
I'm Eleni Tsigas. I represent the Preeclampsia Foundation and Mama's Voices. Although according to my name badge at this particular cohort, I'm the executive director, so. But I am here as the patient advisor.
She's always very, very, very much deserving of a bumps up in grade here. So I'm Brooke Thompson. I'm an OB hospitalist at UT Health in San Antonio. Very excited to be here and working with you today.
All right, good morning. I'm Shad. And apparently I'm hypertension faculty here, which is awesome. I'm a maternal fetal medicine doc. I'm down at Christus Children's in San Antonio. Your traffic and fog are terrible. But happy to be here, and we're going to have a ton of fun doing simulation today.
Hi, I'm Mindy Foster. I'm a nurse, and I lead the service line for our organization, and I live in College Station.
Hi, I'm Jenny Huber. I'm a nurse manager for Women's Services at a level 1 in West Texas at Covenant Health in Plainview, and I'm really excited to be here.
Good morning, everyone. I'm Maria Garcia. I am with DSHS. I'm a special projects coordinator, so if anybody needs anything, just let us know.
Good morning, everyone. My name is Yahaira Rodriguez, and I am education specialist for the SHS, and really happy to be here. Welcome to your learning session.
Good morning, everybody. My name is Nika Schultz. I'm with the Department of State Health Services, and I'm a program coordinator for the TexasAIM program.
Good morning, I'm Esteban Zamora. I'm with DSHS, and I'm the information specialist.
Hi, everyone. My name is Ricardo Gutierrez, and I am the epidemiologist for the TexasAIM data.
So he and also with some help from Esteban are working behind the scenes on the data forum, working on getting data visualization ready for y'all. So we're really happy that to have the meeting in Austin and be able to have such great representation here. And y'all can go ahead and have a seat. Thank you so much. We also, not here yet this morning, but we'll be here later, is Dr. Rocky Domino, and she's one of our faculty. She's also a hospitalist. And then, unfortunately, we heard yesterday from our improvement advisor, Subat Stayan, that she has COVID. So please, we will try to represent her as best as possible on her presentations. Please be patient with us, but she is really sad to not be here with y'all, but looks forward to seeing you again on action period calls. So we also have patient partners who you will hear from in a little while. We have representation from Texas Collaborative for Healthy Mothers and Babies and the Postpartum Preeclampsia and the Emergency Department Project. And then tomorrow afternoon, we will have breakouts with community partners for speed dating with a variety of community partners. So that was a suggestion actually from hospitals at the first learning session to bring partners to a meeting to learn about how hospitals can collaborate and on continuity of care. So we're really happy and excited about that. This is the 5th of 5 of these sessions that we have across the state. So we've had 4 other of these meetings in other areas over the past couple months. And I can tell you that it's a great session, and you will come out of it at the end with your brains full and lots of great ideas. So now I'd like to call the members of the hospital teams up to the front. And where'd that mic go? Oh, okay. Oh, okay, thanks. So if you could send up your representative to introduce your team and your ask and your offer. Don't be shy. Come on in. So again, we'll just ask that you introduce yourself. Tell us a little bit about your team. When your person is up front, if the team could stand so we can see where you're sitting and kind of see who, people can put names with faces and know if, especially when we get to asks and offers, where to find you. And then, so your name, a little bit about your hospital, and your ask and your offer.
My name is MC Urban, and I'm here from St. David's North Austin Medical Center in North Austin.
Stand up, St. David's. They're here.
Right here in the front.
Oh, okay, sorry.
Our offer is we're a high-volume, high-acuity hospital. Last year we delivered more than one baby an hour for the entire year. And we accept loads and loads of transports, so we have tons of experience with that. Our ask, and I saw this on a couple of people's posters, so I think we're in the same boat. We would love to hear more about your postpartum readmissions for hypertension and how we can work towards preventing those and keeping these moms safe once they leave. I think that was it, yeah. Thanks.
Hi, I'm Lauren Montgomery. I am from Ascension Providence in Waco. We are the Stork Squad. We're a level 2 facility just located between here and Dallas, level 2 for maternal and neonatal services. We average about 1,500 deliveries a year. And our offer is actually our work with our emergency department. I think we've done a great job of establishing an order set and recognizing those moms as they present to the emergency department and getting them back up to labor and delivery, as well as doing simulations with our friends in the emergency department and ensuring that all of the antihypertensive medications are readily available in that department. And then our ask has to do with the 3 to 5 day follow-up. We definitely educate that on discharge, and it's provided in our discharge instructions, but I would like to know how sites may be scheduling those appointments or just following up and tracking to ensure that the patient actually had the follow-up within 3 to 5 days.
Hi everyone, my name is Amber. I am the Director of Labor and Delivery at Las Palmas Medical Center in El Paso, Texas. We are a level 4 maternal designated facility. We do a little over 3,200 deliveries a year. Our ask is if anybody has a more timely way of auditing and looking through these charts and getting that data. And then our offer, Waco, is we do have a very good system in place for those blood pressure rechecks, making sure on discharge that they have an appointment or that they come back to our facility within 72 hours for a check. We have an order set. We have, a paper that the physician sign, leave it in the chart. They come back, they present it as a clinical visit. So if you guys want to get with us, I'm happy to help. Thank you.
Good morning, I'm Kelly, and I'm the manager of Women's Services at Round Rock Medical Center, and I represent Round Rock Medical Center in Georgetown, St. David's Georgetown Medical Center, where we represent level 1 and level 2 facility. Our big win is that we recently have added ED to our team, so we have an ED representation on our team, which we feel is really important because we do a lot of our hypertension readmits through the ED. Our offer is our drills. I think we do an awesome job at drills, and we have physician involvement, we have staff involvement, we work with pharmacy, several other departments to kind of get this collaboration going, and it doesn't when we have a readmit or when we have a hypertensive crisis, there's not somebody that hasn't already been touched in a drill. So we're pretty proud of that. And then our ask is for kind of putting together, refining our post-discharge continuation of care. I think we're starting to have those conversations about coming back in or going to the office to be rechecked, have blood pressure rechecks, but it's not hardwired. And we're just looking for resources on how people kind of got that organized and set up. So, thank you.
Hi, I'm Cassandra Dubos. I'm from Freer Regional Hospital. This is my team over here. We have Dr. Marshall, our OB physician. We have Martin Salazar from DSHS. She's our community health nurse for Frio County. Elizabeth Segura is our obstetrical nurse. Megan Joplin in the black jacket there. She's our educator. Infection control. Hello, welcome to the rural environment. And employee health. We have April Minus, who is our quality director, and Lori Keck, who is our ED director. We are in Pearsall, which is 45 minutes south of San Antonio, right off 35, almost to Laredo. I don't know that we have a whole lot to offer. We do a great job with early identification. We do a lot of transferring to San Antonio, like big help with our large hospitals that help us out with really bad patients that we see. We see a lot of hypertension, diabetes, illegals, drop-off babies, you know. And so anyways, I think we do a great job of work there, but I think what I came with is, in the area that we're in, is we see a lot of need for telemedicine, and if y'all see the rules, right, we have to have a policy and procedure for it, and we need help there, so if anybody is doing that, I'd like to network with you and collaborate, and so anyways, we're super excited about being here.
Good morning, I'm Melissa Schumann. I am the Director of Maternity Services in the NICU at Ascension Seton Northwest. This is Becky, our coordinator. She is the guru of all things. Love her to death. Couldn't do it without her. Dr. Carew was supposed to be here, but of course she got stuck in the fog and the traffic. We're right up the freeway, but you know it takes 4 hours to get here because of the fog. Our offer is that we've got a great program in place so all moms go home with a blood pressure cuff who've been identified with a hypertensive disorder in pregnancy. Our ask is those of you who have found out ways to reduce your postpartum readmissions. I have some ideas that I brought with me from the CMQCC from California. That's where I originally came from. And so I'm trying to get that launched. Also, Illinois market, they're using antihypertensives and Lasix 5 days postpartum, reduces their postpartum readmission rate. So if anybody's doing anything like that, come find me. I have some research that I'm working on, but if anybody has anything out there, let me know. Thank you.
Hi, I'm Danielle Martinez from Ascension Seton Medical Center, Austin. I brought with me a nursing leader, Allison Prater, and a nurse practitioner, Janika Harris. We are a level 4 maternal center, high volume. Our offer, maybe I should ask first. We are really struggling with getting our providers to recommend the appropriate follow-up after discharge for hypertensive patients. So we like to learn some strategies around that. And our offer is just that we have lots of really good standard protocols, standard approach to hypertension. We're really good at treating hypertension in the hospital, but we'd like to extend that outside of the hospital.
Okay, thank you. Hi, my name is Christina Killebrew. I'm from CHI St. Joseph in College Station. I have Stephanie Wilson and Lori with me today, and we're a level 2 facility. We do about 2,100 deliveries a year. Our ask is how are you involving your patients in your quality improvement projects? Brainstorming on that, but would love some ideas. And our offer is how we took our red bracelet program that the patients are provided on discharge and have spread that throughout the region to freestanding ERs and clinics, and to get everyone educated and have standardized follow-up for that.
Hello, my name is Carla Smith. I'm from Christus Good Shepherd in Longview, Texas. We are level 3. So our offer is that we've done good with recognizing when moms come in with high blood pressures, acknowledging that letting our physicians know and treating in a timely manner. Also following them into postpartum, make sure they are being watched closely and able to follow up closely after discharge. Our ask is, how are you collecting your data at your facilities?
Hi, I'm Brady Myers. I'm from Ascension Seton Hayes. I'm currently by myself because my coworker is on the way. We are a level 2 maternal and NICU. Our ask is how are you making sure that the doctors follow through with giving the medication within the first 60 minutes? We've had some issues where they just jump straight to MAG and don't actually give them the labetalol. Our offer is our postpartum nurses have been amazing at making sure that anybody with hypertension is scheduled with their appointment before they leave the facility, and it's documented in their chart.
Hi, I'm Heather Thomas. I'm from Dell Children's Medical Center in the Specialized Delivery Unit. We are a newer facility, so we will learn from a lot of you. I brought with me today Robin Polanco, who is one of our shift supervisors, and then Sheree Bailey, who is our department supervisor. Our ask is, how do y'all prevent your 3-day fallouts if a discharge happens on Thursday and their 3-day is supposed to be on the weekend? How do y'all prevent that? And what kind of modifications have y'all done around that? Our offer is that we have a really robust team downstairs that actually does a really good job ensuring that all of our patients have postpartum appointments scheduled prior to their admission to the hospital. So they've done a really good job with that, but we need those 3-day follow-ups.
Hi, and I'm Sherry Sullivan. I'm from Baylor Scott & White in Round Rock. We are a smaller facility, but we are growing. I think our ask is we'd like to see how other facilities are doing it, especially at the level we are at, and also how to collect and disseminate the data so that it's more streamlined and not so overwhelming. Offering a supportive environment for people to approach us. We want to offer up how we are educating our patients when they're going home with further education besides the normal stuff. And we also want to share our processes and our policies.
Hi there, I'm Caitlin. I work at Baylor Scott & White Hillcrest in Waco, Texas. This is my lovely team back here. We are a mixture of, I'm a labor and delivery educator. We have our mother-baby educator. We have some of our staff nurses who work the floor, as well as our program managers for both the maternal side and our neonatal side. We do roughly 3,000 deliveries a year, which is really exciting and has been growing, which is kind of our ask as well, as we're just kind of looking at how everybody is facilitating that follow-up for that 3 to 5 day postpartum. We have a very, very kind of vast and some disadvantaged communities, so it makes that 3 to 5 day follow-up really difficult when you have patients who have transportation issues. So just kind of looking at how everybody is doing that. And then what we are great at doing is we have a really wonderful multidisciplinary team of physicians, and it encompasses our ER. We have work with our ICU. We have work with, obviously, mother, baby, and labor and delivery, and our neonatal staff. So through our drills, and then also through our M&Ms, so are reviewing our case studies all together and having a really collaborative effort through that. So I'm excited to learn from all of you.
Good morning, my name is Julie Lamoro, and I represent Baylor Scott & White Lakeway, and I come with an amazing team. We have Kelly Reed, who is our maternal and neonatal program manager. We have Charlotta Remschel, who is our educator, and we have Jennifer, Tamara, and Kendra, who are our nurses who are representing our team today. So thank you all for coming. So we are a very small facility. We do about 40 to 45 deliveries per month, so we're not doing a ton, but we are small and mighty. What we have here to offer today is that we have implemented the preeclampsia bracelet project, and so we are doing that along with our postpartum 3-day follow-ups, and our nurses are making those appointments for our patients that need them. And so I think we've done a really good job with that so far. It's not perfect, but it's a work in progress, and I think we've done pretty well. Our ask today is around education and sort of follow-up for our patients in the emergency department. So we're struggling to identify our patients who are coming through the emergency department. Sometimes we'll find out 2 days later that one of our patients was seen in the ED for hypertension, and they were discharged and treated there, and we never knew about them. So we'd like to find out how you're identifying them and how you're managing that. So thank you.
Hi, everyone. I'm Jules Milburn. I'm here from St. David's South Austin Medical Center. Go ahead and stand up, everybody. So we are here today to kind of help out with some of y'all's questions regarding follow-up, because we actually have come up with a pretty good solution, I feel like. We started implementing a hypertension clinic at our facility, so patients can return within that 3 to 5 day period and get that follow-up that they've been looking for. So if you're interested in something like that, please come talk to us. So we've seen some pretty dramatic improvements in that process. And then our ask is just to continue working on like process improvements, and we're really interested in some ideas that we'll learn here, especially with implementation in like simulations and things like that.
Hi, my name is Jennifer McAdams. I'm with Baylor Scott & White and Temple. My team's over here in the corner. We have about 3,000 deliveries a year. We're a level 4 maternal and neonatal facility in a CREDA referral center. Our ask is just any tips on making data collection easier and how you're getting patient involvement. And then recently our system developed a new algorithm that's much easier for our frontline staff to follow. So that's what we're going to share.
Good morning, my name is Jenny. I'm the nurse manager for Baylor Scott & White Marble Falls. We are small and mighty as well. My technical leader, Megan, is here as well. Our offer, we've recently implemented distributing blood pressure monitors through Breast Pump Depot. That's gone really well for us. And our ask is how to include patients in process improvement initiatives.
Hi, everyone. My name is Beth Henson, and there's my crazy team back there. We're from St. David's Medical Center here in downtown Austin, and we have 5 of our 9 team members here today. We are a level 4 maternal and neonatal facility, and we also house the transport team for our partnership hospitals at our facility as well. So we're a busy place. We're remodeling right now, and we just had our maternal survey. Not fun, don't recommend, so sorry. Just concentrate on QAPI, that's all I'm gonna tell you. Anyways, and so our offer is we have a very robust and revised hypertension protocol that we'll be happy to share. Our ask is we've gotten it hardwired for our patients to do the 72-hour to 1 week follow-up, but how are you guys ensuring that they're actually making those appointments? Thank you.
Good morning, y'all. I'm Darcy Robert, the quality specialist for Texas Children's North Austin. We don't actually exist yet, but we will be very soon, February 1st. So because we don't exist, we don't have a lot to offer, but we do have a lot of really excellent evidence-based protocols from our sister hospital in Houston that we would love to share with anybody who wants it. We also have a really robust QAPI process that stems from that Houston, so we would love to share that with anybody who wants it. Our ask is to know every mistake and misstep and regret that you have so we can start off on the right foot going forward. So, thank you.
I'm Andy Howell. I'm a perinatal quality program manager, and I'm representing Christus, St. Michael, Sulphur Springs, and San Marcos, so we're in the back corner. And I think for our offer is we have a really robust QAPI, like we're still learning, but we have a good hardwired process, and we are going to be initiating our blood pressure cuffs at home. So that's a huge win. It took us from January to now, because from the last AIM, and probably our ask is our ED, postpartum patients or pregnant patients coming in and identification. So.
Good morning, my name is Hillary Hill. I'm the representative from UT Health Tyler. I'm the perinatal nurse educator there. Our offer, we have currently a good system of efficient identification and early intervention for our preeclamptic patients. We have our eclampsia carts that we pull in front of their doors, and we utilize the color code system on their door frames that we to better help our nurses and our nursing staff to implement interventions earlier. Our ask would be, especially since I'm newer to my role as an educator, would be, how do you do your simulations? Or better yet, how do you involve your physicians in your simulations? Do you make them spontaneous? Getting nursing support is as easy as pie. It's getting physician help that we're struggling with a little bit. But that would be my asks from that, is how do you get your physicians involved, and if it is spontaneous, or do you schedule it out way far in advance? Thank you.
Thank you. All right, give yourselves a great big round of applause. There's so much knowledge in this room, and just a great opportunity over the next couple of days to gather that. I just wanted to take a brief moment to ground us in why we're here, and you'll have more of that in a minute with the patient panel. But we are here because we have opportunities to reduce severe maternal morbidity and mortality among women with preeclampsia. As you can see from this chart, that there are some vast disparities in poor outcomes. And so to move the needle on our overall rate, that dotted line, we have a lot of work to do in closing these disparity gaps. We know that lowest line, and you know, the lowest rate on this chart is definitely achievable. We've achieved it before. We can do better than that, and we can do better than that for all moms. We know that it takes more than just the work that you're doing in the four walls of your hospital. There are a lot of factors that go in that contribute to severe maternal outcomes, but you have a real opportunity to, in your setting, to first of all identify and treat severe hypertension, but then also to help prepare your patients and connect with your community around creating that continuity of care and the follow-up of care, including for folks maybe that don't even have severe or have hypertension during the hospital stay, but a few days later do. So we thank you for being here to help us reduce the rates of severe hypertension in pregnancy. I'm going to race through these a little bit to get to what I want y'all to know. On your table, you have, at registration, you got this blue folder. This has all the materials that you'll need during the next couple of days. One thing I would like y'all to pull out now is the simulation, pre-simulation survey, and fill that out, please, sometime before lunch. And you can just leave it on your table and we'll pick it up later, but we'd like for you to fill that out. Also, if you haven't set up your storyboard, there are supplies and you can do that anytime before lunch. Please take breaks as you need to. The bathrooms are out this door and just they're kind of tucked back around a curve. And if you need a lactation room, we do have one, so just ask at the registration table. If you have special dietary needs and you need to, can't eat off the food line, also let the registration table know. Wanted to let you know this afternoon, if you want to meet one-on-one with TexasAIM staff or faculty, please put your hospital name and your question on the office hour sheets on the wall, and you can meet with us at, after the session today to just answer any questions that you have. And tomorrow morning, bright and early, 7:10, we have our technical leaders meeting, but anybody's welcome to come to talk about data. We want to hear from you about your questions around data. We'll walk a little bit through the data reporting form and process, but then also open up the floor to hear from you about your challenges, your questions, your needs. And we really appreciate you joining us to provide that feedback. To set the stage for today, which we already have with the asks and offers, but this is not a conference, it's a learning session, it's a learning environment, and it's a safe place for you to learn, and you all have plenty to offer. And then also, I'll have something to learn. So please come throughout the next 2 days with that spirit. All learn, all share, build your network. There'll be several opportunities where you'll be able to interact with teams from across this great big part of our state. So, get people's emails and phone numbers and write down your questions, because you will have a full brain at the end of this, so make sure to jot down those ideas so you can go back to them later and bring it home with you. That's what this is all about, is getting more ideas, bigger change ideas, and really getting a stride over this next action period for the changes that you're making in your setting and your community. And at the end of each day, please do fill out your evaluation. We'll read that tonight and put those recommendations into action tomorrow. We'll also, if you have questions, we can address those tomorrow and through the next action period. And most of all, have fun. This is a really great 2 days. Time to be with your team, time to be with each other. And we're so glad you're here. And now I'm going to call Dr. Carrie Epps up to the stage to share with us about the state of the collaborative.
Thank you. Any tricks with this guy?
No, I think it works now.
Good morning. I get the pleasure of reviewing what we know as far as data for how you guys have done to this point. But I want to pause really quickly. I think it was, we adapt each one of these sessions, and you guys are the last in this round. So hopefully by now we've kind of perfected learning session 2. But one of the newer things is having everybody come up and say what they want to get out of today and what they can offer. And that's such an impactful moment. Things like innovative team ideas like implementing an eclampsia cart, anything that we've had here that National AIM has recommended, an entire hospital that isn't even open coming to participate so that they can shape their labor and delivery in the safest way possible. And then so many of you who have been here from the beginning of hemorrhage onwards. So thank you for sharing. The other really important thing is this model of implementation is all about peer learning and sharing, and that's what makes it so much more rapid as far as the change we can accomplish. So when you guys come up and say what you need help, listen to each other, and that's exactly what we want today to look like. So while we have a script, while we have an agenda, today is about what you all need so that the data that Julie just showed looks really different in a year from now. So be vocal, interact, let us know if we need to shift gears, and also let us know what you need in Learning Session 3. So really quickly, I'm going to kind of frame what we know from all of you. Before I start that, I'm just going to say we have heard loud and clear that data is a very important thing that everybody needs additional assistance with. So a lot of what I'm going to show you is from us kind of trying to pivot and doing a mid-course survey to hear what you need when we might not be able to see that in like the quantitative data, but we're going to keep working on that piece with all of you. Okay, so quick reminder. This is what we all sat down with intention to start working on. So this is our driver diagram. A very big thing that's different in hypertension compared to the work we did together for hemorrhage is for hemorrhage, we just took what National AIM said
is an important thing to do in the hemorrhage bundle. And you saw the slide that Julie started with our pervasive racial and ethnic disparities. And so we know for our hospitals and for our patients that all of these blue equity elements are so critically important. So this is completely adapting to what we know we need to be doing internally and making it a little bit more Texas personalized. So I'm going to go through something that Julie and Jamie and Sue and I worked on to kind of craft and repackage the things that we've heard you guys are excelling at. So when you see that, recognize that there are teams successful. Don't feel bad if this is something you're still working on, but it means there are a lot of people in the room who can help and give you good ideas and have probably made the mistakes you're making. And then to the things that are in red to show kind of why we're bringing the things we are to this learning session and what we all need to be progressing in. So as a reminder, the work we're doing is framed as primary drivers. So the first is readiness. So how much are our units structured and ready to support severe hypertension? And in this graph, or this diagram, all of the blue is those specific elements for equity and shared decision-making and trauma-informed care and all of those components that we know are so important. They're also the things that you guys consistently say you want the most support in working on, so a lot of this learning session is structured that way. So I'm going to kind of keep coming back to where we know we are currently, and then what is being brought today so that you know that that's what you need to focus on if that's what you still need work with. And then we're going to flip and hear from our patients, because obviously the two reasons we're here is because of the impact it makes on all of the women we're caring for. And then when we take all of those individual women together, the data shows us what everyone needs to be working on. So as a reminder, a lot of that is what you guys just mentioned, and you're doing fairly well in readiness, right? Many people have a protocol, many people have ready access to medications, many people have made really good progress in maternal early warning systems. So huge kudos to you guys. The next aspect is in recognition and prevention. So a lot of this is, how do you know when you have a patient with severe hypertension? I heard you guys just reflecting on needing to expand that to areas like the emergency department and outpatient centers. So those of you who are doing well, please speak up as we're getting to that point. But also the importance of screening for and adapting your plan for social drivers of health. So I'm going to say this again, but the entire second day, we have a big focus on, number one, realizing where cognitive biases impact our patient care, and number two, how you assess and adapt your medical plan to meet patients' social-related health needs. So that is why so many of you were talking about, all right, you can make the appointment, but how do you make sure the patient actually gets to it? And that's, of course, our entire goal. We're measuring whether you made the appointment, but it doesn't matter if they can't make it. And so much of that is related to the things you guys just mentioned, like transportation. What is their insurance? How do they have to prioritize what they're spending their time with? And so that's going to be a big focus of tomorrow afternoon. The next R is response. A lot of that is treatment. I've heard you guys talk about the measurement aspect of that and how challenging it is, but also how we do trauma-informed care. And it keeps coming up that this is something that folks really want more specifics of, not what it is, but how you adapt your protocols and the way you're caring for patients to actually be doing trauma-informed care. So we will be showing pieces of that, and it will be coming forward in the next action period. And then finally, reporting and systems learning. So a huge portion of this is what you guys just talked about, and what we're doing so much statewide with maternal levels of care and QAPI and case review. So tomorrow, again, we're going to do an entire section on when cognitive biases, such as implicit bias, play a role in our patient outcomes, and how you identify that in doing case review, and how you change things in the way your unit is caring for people because of it. As well as tomorrow morning is an entire data session. So we want to be hearing more from you about the specifics of help and what you need. And I keep hearing how do we make this easier? What are tools? So if you can give us more specifics, we can bring them to you as well. But there are hospitals doing a really good job with reporting. And this is also very interesting this time. We were talking last night in our faculty dinner. For example, Cohort 1, which has a lot more rural hospitals, sounds like it's actually out-reporting, for example, Cohort 4, meaning as far as being able to report data, which is largely the entire Houston area. So sometimes being smaller is actually making you more nimble with data collection. So I think learning to see the hospitals that are what your level looks like, or where your EMR looks like, or your infrastructure will help you be able to take those tools back. And we're also learning along with you. And then finally, respectful care. So if you go and you look at the national AIM bundles, which obviously have gone through a big change recently, they added this 5th R, or respectful care. You'll probably notice when I showed that big diagram, all of the blue colored elements, we actually made them through every single R and then added in respectful care. So we've done a little bit of both. But this is basically how do we make sure that we are involving patients and their experience, and how we're listening to what we need to improve, how are we doing shared decision making, how are we doing trauma-informed care, which is so important. Okay, so a little bit about how you look right now. So again, I think about 50 hospitals out of all of us are consistently reporting data. That is much lower than it was for hemorrhage. So I just want to say we hear you, we know this is something that we need to be working on with you. But it also means that we had to take that information and also other information to know what you guys need. So we did a mid-course survey, which is a little bit more qualitative as far as what you guys feel like you want to be focusing on. And a lot of this information comes from that, and that's how we shape the learning session. So again, some of this is kind of formatted in terms of those R's that we just went through and the primary drivers. And what we asked is, where are you in implementation? So a 1 is you haven't started it, and a 5 is it is in place, it is sustained, you feel very confident that it is consistently implemented. So for the sake of the things that you're going to see, the lovely Dr. Morgan has color-coded them going forward. So in general, 1 is going to be the red stoplights, and green is going to be the green stoplights, and that's the fully implemented side of this. So I want to show you what you guys look like at this point, which is exactly where you should be midway through our collaborative. All right, so areas of success where you all have expressed that the majority of you feel like things are either at a level 4 or 5, so very far advanced in implementation. And again, that's what you're here to share with other people. So if you feel like you're all in the green, you're exactly the people that need to be here to bring everybody else up. So this includes things like standardized protocols, order sets, escalation for maternal early warning signs. I'm going to pause and tell you how happy I am that we're at this point in hemorrhage. Like, it was definitely a 1 for the majority, so you guys have done massive amounts of work in the last few years. But also things like timely treatment of hypertension, magnesium to prevent eclampsia, and then rapid access to medications. And that includes everywhere. And finally, process for timely treatment and evaluation on your labor and delivery units. So those of you who said you want to know more about other areas like the emergency department, you're in very good company, because that's all of us. Other things you're doing really well: system plan for escalation, again, maternal early warning system protocols and implementation, ongoing culture of communication, teamwork, simulation, and drills. We still are focusing a huge amount on simulation, because even if your teams are using that tool a lot, there's so much more that you can do with it. So midway through this, we adapted and made the second simulation focused on the emergency department. Please take that and bring it back to your emergency department and use it to figure out where your gaps are and what you guys need to do. So not as a, I'm testing, do we all know, but you can also be using it to figure out where are the things that you all need to be working on together. And there is nothing more eye-opening than actually seeing it rather than being told. So doing that simulation together with ER leadership will be huge. Other really important areas of success include ongoing education to both your healthcare team and family members, establishing a culture of respectful, equitable, and supportive care. I in particular was really happy to see you guys feel like you're making good progress there. Consistently doing case reviews on cases of severe hypertension, and improving the communication with patient families and trust building. So kudos to you guys in all of these areas, and this is where you need to focus on sustainability. Just like hopefully that's where you are for a lot of hemorrhage, things can still change and pick up. And we know in this post-COVID era, there is a ton of turnover. So you're gonna have new team members. So this is where we all need to be focusing on how do you make sure they know exactly what this looks like. For me, one of the most exciting moments was when we hired a bunch of new faculty, and so many of them had come from other areas of the state, and one of them, and I don't know if he was just saying this because he knows what I do, but he was like, this is exactly the same as what we do in San Antonio because it's all AIM stuff, so I know all of this, it looks the same. And it was this perfect moment of, once we get our spread large enough, it should look the same in every hospital. It should be the expectation everywhere, and that should make it easier. Okay, areas of opportunity. So you're kind of in the middle range here, so we can all really be working together to improve this. Do you have a process for timely treatment in emergency department and outpatient areas? So we are all here. If you're doing something really innovative, make sure you share. The other thing is on day 2, Susan, will you raise your hand? So Susan's here from TCHMB with the postpartum preeclampsia in the emergency department project. So one of the things that we'll do, half of you are doing our social determinants of health sim. The other half is going to be meeting with community partners. And one of them is going to be Susan talking about PPED and how to kind of build an experience from the hospitals that are doing that dedicated project kind of embedded within TCHMB. And you can get ideas and tips and interaction and tools that have been developed in that setting. So I'm going to pause. That was completely from something that was recommended by you guys last time. I actually think it came from Cohort 4 in Learning Session 1, and they said, can you bring community partners to us? Instead of like us trying to, in each of our communities, figure this out, can you bring some of them to us? So things like nurse-family partnership with home visits or health departments and what services they have for blood pressure cuffs and things like that. So in that day is bringing some of those community partners to you guys. Now, you're from a lot of different areas, and a lot of them are from Austin for obvious reasons, but you can look and see. For example, the Nurse Family Partnership team is from College Station. That often exists in all of your communities. So even if the exact person isn't there, ask them, how do I figure out who that is in my community so that you can work with them to expand that part of postpartum follow-up. So other things that are kind of in the middle include data tracking, especially in relation to things like maternal early warning system, response, and treatment, and lab assessment, and then ongoing education regarding health disparities, trauma-informed care, and shared decision-making. And this one's really hard, so I'm extremely happy to see that you guys identify it's in the yellow area. Because early on, I think a lot of us said, all right, check, I showed a video, I'm done. And that is not truly implementing it, making sure folks understand it, that we are adapting. This is an ongoing process that we will all probably be working on in our entire careers. Okay, other important areas of opportunity. Documentation and feeling comfortable that our electronic medical record or our source of saying what someone's payer, language, race, ethnicity is actually accurate so that we can be looking at our own data to see where disparities exist. We hear this over and over and over, so we hope to be bringing you guys some toolkits from other folks who have been doing this well. Assessing and documenting if someone is pregnant or postpartum, especially as they come into the emergency department. Again, we've had a number of hospitals really doing dedicated work on this, and Susan will be sharing. Screening for clinical and social drivers of health and risk factors, and I'm just going to tag on and doing something different for your patient when you hear that that's the need. And I think that's the piece. So much of us are screening. I think obviously a lot still need to work on that, but do you actually do something different? If your patient has transportation insecurity, what does your hospital have to make sure they can actually make it to the pharmacy, to the postpartum visit, to an emergency department if they need to? And how do we adapt that and actually do it as a team member? One of the most eye-opening things has been everybody thinks that's someone else's role. And I can't tell you how many people have said, oh, I thought the case manager did that. I thought the social worker did that. I thought the doctor did it. You know what that means? None of us are doing it. So it's something we all need to be working on. Providing comprehensive discharge visits, including the use of a standard discharge summary, and scheduling follow-up to occur in the appropriate time frame, just as you guys just identified up here. How do you collect and review patient and family experiences and adapt your care because of it? We're going to have an entire patient panel here just in a minute to kind of give you some advice on what would be meaningful to them. Establishing and using standardized case review process that considers the role of cognitive bias. Again, tomorrow has multiple hours of focusing on that, and I hope it's really eye-opening for you guys. We did a little bit in a prior action period call, but we're actually going to work on it together tomorrow in great detail. Disaggregating outcomes, so that takes knowing what your patient's race, ethnicity, language, payer status, whatever your disparate outcomes are related to, and being able to look at your data to assess that, and then doing shared decision-making that includes patient preferences. So again, this is why this learning session looks this way. Please continue to tell us what you need to focus on, and just know that you're not alone. This is where we all are together, but you've already made absolutely tremendous progress. Okay, our biggest areas of opportunity. Trauma-informed protocols. Got it. We will really be focusing on that coming up. If you're doing something well, come tell us so that we can tap into what you're doing in future action period calls. How you engage and include patient, family, and community advocates in your processes. Again, we have the entire Community Partners Fair tomorrow to try to help bring them to you. And then we've already talked about the trauma-informed care piece and ongoing improvement with equity. So that's why today looks the way that it does. These are the things that we are bringing forward based on what you guys said you need in that mid-course survey. I would love to see us also being able to incorporate that quantitative data in the future. We know how important that is, so we need you to keep letting us know what tools and support you guys need to be able to do that. You know, if you are, and thinking about this too, this is very much of a longitudinal experience, right? What we learned in hemorrhage helps set us up for hypertension. This is going to help you guys in sepsis and cardiovascular disease. So as you're working on things with the ER right now, that is a very big task. But if you can get them to assess when a woman has delivered within 365 days, that's going to help us so much as we work on sepsis and the cardiovascular bundle, right? So the work you do now, you might not see it immediately, but it's going to make a big difference in the future as well. And all of this is helping us build this infrastructure and team to do this work going forward. So thank you for everything that you've done. I'm going to turn it over to Eleni and our patient and family partner panel to talk a little bit about their experiences and help us with the pieces that you guys have identified in needing to incorporate their voices in our improvement. Thank you, Eleni.
Usually it takes a couple tries. Ooh, see, I told you it's going to take a couple tries. Okay, can those in the back hear me okay without it booming? Okay. By the way, there's Kleenex here. Put that between you. So, show of hands, how many of you all were not at learning session 1? Ooh, a good number. Okay, so this is new. You may be surprised that we actually brought patients to this experience. Wow. Might be a new concept for some of you, but let me give you some context here. I mentioned in our quick introduction, and I know this keeps going out, I can hear it going out. Can you guys let's see, make sure what's going on here. Hold on. I hate those. Okay. All right, we're going to assume this is going to keep working. If it goes out and you're having problems hearing me, just give me a little wave in the back. Okay, so I mentioned I'm with the Preeclampsia Foundation. We're a patient advocacy organization representing, obviously, hypertensive disorders of pregnancy. If I were to summarize what we do and what we hope to do, obviously it's to improve the outcomes of preeclampsia, but we do that through the lens of the patient, right? We're not trying to duplicate a professional society, ACOG, A1, ACNM. All of those are our partners in this work, but we do the work that we do through the lens of what is this experience like? Where are the gaps? Where are the opportunities through that patient experience. And so what I've done today is brought some patients who have experienced a hypertensive disorder of pregnancy. They're going to talk about their stories, and we're doing this for two reasons. One is to motivate your why. Sometimes this work can be exhausting. Sometimes it just starts to feel like I'm just going to work and trudging my way through another day. And at the end of the day, we're doing this work to improve outcomes for those who have experienced this. So if nothing else, I'm losing it again, aren't I? If nothing else, hello, I'm like this. If nothing, oh no, it's still going out.
Yeah, I can hear that it's still on.
Okay, hopefully we'll hang in there. So I was saying that we want this to motivate your why, and I always say that we're here to tell our stories to engage your heart, but also to engage your head. Because what I want you to do is to be able to listen to the stories with also an intent to learn from them and be thinking like, hey, could that have happened at my institution? Is there something that's happened at my institution that these women are bringing to light for me that we need to go back and think about? How are we handling this? Is there an opportunity to take an idea that they have suggested and maybe test this, right? We talk about our PDSA cycles. Is there a way to just test this with a few patients and see how it goes? So I really want to emphasize this idea that we're speaking to your head and to your heart. Our patients are going to stay and participate in the simulation training. That is one, we heard many people up here say, we don't know how to engage patients. Maybe involving them in some simulation training. Because I guarantee you, having been now through all of these cohorts and being present in all of these sim trainings, one of the biggest weaknesses is that when you put a staff person to play the patient, they don't get it. I often say, you all live in this world. We walk in like we walked into a foreign country. When we walk in to have our babies, it's like I'm in a foreign country, I don't speak the language, and I have no idea what the customs and culture are of this place. And so while you may have a staff person, in fact, if I were to ask for a show of hands, how many of you all have actually personally experienced preeclampsia? Smaller than most places, but I'll tell you, in most, 10% of you will probably have had some kind of hypertensive disorder of pregnancy. I encourage you to learn from your staff who experienced this, but know that that is still going to be not the authentic, naive perspective of those of us who come in and do not understand your world. So if you can invite patients who truly are not from the healthcare system to participate in your processes, you're going to gain a lot of insight from that process. I want to encourage you to listen without correcting for what you might believe is wrong medical information. Our patients are here not to be medically accurate, they're here to represent their perspective. And in fact, in many ways, I say that this needs to be a brave space. We talk a lot about having safe spaces. I think safe spaces are great, but what that implies is that nothing can be said that isn't going to trigger us. And that's not necessarily the case here. This needs to be a brave place where your curiosity is what's leading your intention here. And same thing with our patients, right? They are stepping into a brave space. They're revealing very private experiences that they've had. And so I just really want to encourage all of us to think of this as being a brave, judgment-free zone where we lead with curiosity. So having said that, let me quickly introduce who we're going to be talking with this morning. Both Melissa and Leah come from the Austin area. It doesn't matter what hospitals they attended. We're here to talk about their experiences. And I'm going to ask each of them to just start with a quick synopsis of what they experienced, and then we're going to get into some discussion, and there's going to be opportunity for Q&A. So if you think of questions as they're talking, feel free to jot them down, because we will get to that. All right, Melissa, would you mind starting?
Sure. Can everyone hear me okay? Hi, so my name is Melissa. I am mom to 2 young boys, both of whom went through preeclampsia with me. And I guess I would say I'm one of the lucky ones because my pregnancies were relatively uncomplicated. My births and deliveries were relatively uncomplicated. And it's only actually in recent years that I've discovered how sort of uninformed I was and didn't realize I was about my condition and the potential implications of that immediately postpartum and on, actually, for the rest of my life. And so that's sort of the perspective that I'll be bringing today.
I'm Leah, and I have almost 7-year-old twins, and I went through preeclampsia HELLP syndrome. Mine was kind of a pretty extensive journey. What started off as a pretty typical twin pregnancy, rough, kind of took a big turn really last minute. I went through kind of the gamut of it. I had preeclampsia, but my baseline of my blood pressure is extremely low naturally, so it wasn't quite detected. Then I was showing signs of liver failure, which was dismissed by my MFM as a normal pregnancy signs. And then I had my twins and went into an emergency C-section because she had decreased fetal movement. And I kind of never woke up. I spent 6 months off and on in the hospital. I had 5 surgeries, went through DIC, emergency C-section, implosion of my C-section, abscesses throughout my abdomen. So I had a laparotomy, I had sepsis. What else did I have? I didn't lose my pancreas, but my pancreas has been damaged. So I'm now a type 1 diabetic, no gestational diabetes, completely healthy beforehand, lots of long-term complications still ongoing and for the rest of our lives. Both of my children are healthy, but we did have some complications with my daughter. She had severe brain damage from the 2 days that she was not fully oxygenated. And I mean, I'm here to just share what I can and talk to you about the situation and how I can help you guys help my children and their children have healthy births as well.
Wow. I know Leah's story, and honestly, like the journey that you've gone on and continue to go on could be the subject of a 4-hour documentary. One of the things that we're cognizant of is that this particular learning session, there's a lot, we talked a lot about patient education in the first learning session, and several of you have done things like implemented the red bands, which we're excited to hear. Hopefully you've incorporated some consistent practices for ensuring that patients go home knowing signs and symptoms. This learning session is focused a lot on the discharge process and how follow-up needs to happen. We know that preeclamptics or anybody who is at higher risk for a hypertensive disorder really needs to be checked a few days right afterwards. And then, Melissa, as you've commented, like the whole long-term piece and our much higher risk for having cardiovascular disease is something that's not only not discussed, I think it's often not even known by a lot of healthcare providers. Let's talk a little bit about your experiences. You had preeclampsia. Let's start with you, Melissa. You had preeclampsia, both pregnancies. Thinking back to the first pregnancy, when you truly like had never experienced it before, what was that discharge process like, and what was talked, how were you communicated with, and what did you learn through that?
Yeah, what I think what I learned was from the absence of discussion. I don't remember anyone discussing preeclampsia with me in the recovery process at the hospital or in the discharge process. It's interesting being here and hearing references to all the work that's been done on hemorrhage, because what does stand out to me is the communication around bleeding and what's normal and what's not normal, and that was not on my radar pre-delivery process, and I felt like that was a really successful embedding of information. It got repeated a lot. There were visuals of like a clot that's bigger than an egg or whatever the size was, but nothing like that with preeclampsia. And my OB had essentially told me the cure is delivery. So, I delivered, my baby was healthy, I was feeling okay, and I just kind of thought, this isn't something that I need to be thinking about anymore. And I remember asking my husband after we got home, did anybody talk to you about, should we still be thinking about this preeclampsia thing? And he was kind of like, no, I don't think anybody mentioned it. I wasn't recommended to follow up with my OB. My own OB didn't want to see me until the usual 6 weeks postpartum. And
So you didn't see anybody till 6 weeks later?
Correct, yeah.
I think you mentioned to us that you actually had a home blood pressure monitor.
I did, yes. So I think at about 35 weeks was when my first kind of high reading was detected at just a typical appointment at my OB's office, and she had recommended that I get a home cuff then. And I can't remember if I asked, so my own OB didn't round on me in the hospital, it was another OB from the practice, and I can't remember if I asked her then in the hospital or if I called the practice once I got home, but in the first few days postpartum, I asked someone from my OB practice, should I still be checking my levels when I get home? And my memory is the answer was it wouldn't hurt, essentially. And so I did when I remembered to, but I was also, adjusting to having a brand new baby to take care of, and just sort of thinking I delivered, check, it's done. So it definitely wasn't something that I was consistently doing or encouraged to do.
So you had preeclampsia again the second time, and was that a surprise to you, or were you given any additional information because of your first experience?
I was given some additional information. The OB that I had had with my first pregnancy had left the practice, but I went to the same practice and had a different OB. She was familiar with my experience the first time, and I think even before I conceived, I went to have my IUD removed to start trying for a second, and we talked about, am I at higher risk? What would we do during the pregnancy? And so I did have a regimen of daily, whatever the baby aspirin dose is, and I was monitoring my blood pressure occasionally. My OB actually recommended not doing that religiously unless we got concerning readings in the office, because she was like, don't stress yourself out checking all the time. But I felt like my care during pregnancy was pretty great both times. With the
Can I interrupt a second and ask, what's your thought about the whole don't take your blood pressure, it's just going to stress you out? As somebody who's experienced preeclampsia, is that valid, or do you feel like that's true?
I think when you've had preeclampsia, that level of that sort of niggling, should I be worried about this, is there whether or not, at least for me, whether or not I was checking my blood pressure. So I don't know. I think I did check it occasionally, like I said, and my readings, especially in the beginning of pregnancy, were fine, and that was reassuring for me. If I'd been checking it and seeing high numbers, maybe that would have been different, and it would would have been more stressful. But again, at this point, I hadn't done research on my own or talked to other people who had had preeclampsia, medical professionals. So I was still sort of thinking, like, if I needed to know something, my doctor would tell me. There's nothing extra that I need to be doing on my own here.
Sure. So there's more that I want to unpack about your experience, but Leah, you're at the other end of the spectrum because you went home with so many medical complications. I almost feel like the same question doesn't apply, but in some ways it does, in the sense of what were you empowered to do, and what were the expectations for your at discharge and immediately following up?
So my discharge was, I think, extremely different, because the first 5 weeks I was hospitalized, and so there was a lot of trying to figure out what to do between my OB, the MFM, and then all my other doctors. So I didn't mention this, but I went into multi-organ failure. So I had my liver, my kidney doctor, I had my hematologist, I had so many doctors, and I had a lot of conflicting. So one would be like, you need to drink more water because my kidneys weren't working, and then someone would come and be like, you don't need to drink that much water. So I was just constantly confused. I remember a social worker coming in and asking questions, but for the 5 weeks that I was initially there, I was completely out of it. I mean, we joke now about the delirious conversations that I had. I would kind of envision things that were going on. I would say things, and my family's like, that never happened. So I wasn't actually fully coherent. They were telling my husband, but at this time, which is a whole nother conversation, my husband was told that my daughter's going to die, I'm going to die. And he's a complete mess trying to figure out, how did this happen? Nobody's ever warned us of this. So whatever they told him kind of went in through one ear and right out the other. So I remember going home with a packet. It was huge. And I had no idea. I had 2 packets. One was mine and one was my children's and my daughter's mostly. And I had no idea what any of that meant. I just know that the most important things were, because my kidney specialist kept saying I need to drink water to make sure to flush out, to try to get my water going, and to start peeing more and all these things. And it was almost non-existent. I didn't know what preeclampsia or HELP syndrome were. I know my OB briefly kind of educated me or kind of talked about it, but in my head I still thought, unhealthy people get this. Like, it must have just been a fluke. Something happened, because I'm pregnant with twins. I didn't quite understand what it was, but because I was in the hospital a lot, I had a lot of time to research. And that's kind of how I started educating myself, which was a good and a bad thing because I saw all the worst of the worst through Dr. Google. But I just knew, I think this is a little more extreme than actually people are telling me. And I don't know what was being kept from me too, because I was also on a very huge mental decline. Like, I didn't want to see I didn't meet my children we didn't meet at all until 14 days after birth. I didn't want to see them. I actually could care less. I didn't even quite understand that I had children. So my doctor knew that I needed to create that bond because they were left in the NICU with very minimal interaction from any adult. So
it's interesting because I'm thinking about the mental consequences of what each of you went through. And Melissa, you suffered from too little information, and you suffered from too much information. Like the understanding of what happened to you clinically. And one of the things we talk about is having like a one-page clinical summary that just puts forth the accurate information in a way that a patient can understand, this is what happened to you, this is what you need to carry forward. And, because you've talked a lot about the fact that you were just overwhelmed with information.
Mm-hmm.
What could have helped you?
A summary, definitely, because I was seeing so many different providers, and they would change because some were hospitalists, and then I wouldn't see them outside. So I had to get a whole new one. Trying to put everything on the same page, it was really hard to tell your story a few weeks out. when you kind of don't understand your story. And, you know, you trust your physicians. They're supposed to tell you what's wrong and what you need to know. And culturally speaking, I was raised as a Hispanic woman to trust what the professionals say. You know, they've gone to school, they've done all their work, and they care about you. And so everything that they said was right, and I just felt like there should have been some breakdown, and also maybe fake, like my situation I feel like is not the norm, because obviously I was constantly in the hospital. I was just continuously sick. I was very sick when I went home. We fought for me to go home because I was getting worse and worse, and we felt the best thing for me would be to be home, which I don't know how good that actually was. But basically breaking it down into layman's terms and sitting down and then having me reiterate what was going on, what had happened, me and my husband, because we had infant twins at home that we had to figure out how to take care of. I mean, I was like an infant. I had a whole protocol of things that I had to do. I went home with JP drains. I went home with a wound vac. I couldn't walk. I had to relearn how to walk. It was just like I couldn't carry my own babies. There was just a list of things that kept me from doing all the other, like going to go see a doctor, even though I had a million doctor visits afterwards, was not my top priority. It was just, I just wanted to be home. And so if somebody was there, or someone calling me and saying, have you done this? A navigator, a community partner, have you done this? Instead of me reaching out, because I didn't even know I was supposed to reach out. And then I found paperwork like 9 months later that I was supposed to call this center and they would help me with this, but I didn't know what that meant.
Mm-hmm. Oh, it's overwhelming. I mean, it's overwhelming in a, quote, normal pregnancy where you bring home a baby and you're sleep deprived and, you know, there's this new thing I'm supposed to take care of. Like, even the simplest can be overwhelming. I can only imagine the complication. So you mentioned something, and Melissa, maybe both of you can touch on this a little bit. When it comes to our support partners, our spouse, partner, whoever is sort of in this with us, what's their role in all of this, and how did you all experience their role for you? And what did they get or not get that they might have needed?
Yeah, I can speak to that a little bit. My husband and I actually did Bradley method birthing classes. I don't know if people are familiar, but it's like 12 weeks. He was a certified birthing partner. He got a little yellow card that he was supposed to take to the hospital to show that I know what delivering a baby is about. So we were very much, even before the preeclampsia diagnosis, he was supposed to be sort of the level head, the person absorbing the information when I didn't have the sort of mental or emotional capacity to. He had his list of informed consent. He was a
professional advocate.
Yeah, exactly. And so, I think I mentioned earlier at some point near postpartum, I had asked him, do you remember anybody talking about this? And part of why I asked him was this was your job, man. You were supposed to be listening and absorbing the information. And so, yeah, that's sort of what I felt his role was to help catch the things that I couldn't. But, you've hinted at this. It just strikes me that there are so many people who have more complex situations where, I don't think he could have been that person if my life was actively in danger, or the life of our child. And then so many people who just don't have a support person, full stop. So, yeah, I think I wish that he had been given more information, but also for people who don't have that, I don't know what they do in those situations.
So I'm asking you to speak for him, which is probably not fair, but if he were
I do it all the time.
If he were here, would he say he was, how would he describe how he was treated and engaged by the staff?
I think he felt very engaged by the staff and my OB throughout the care process. I was actually really happy that I didn't feel any of the sort of, I don't know, old gender norm stigmas of like, you know, he's just there to smoke a cigar when the baby comes or whatever. He was sort of by the bedside going through the briefings and the paperwork and the discharge instructions, and the staff were very much treating him as like an integral part of that conversation. So ultimately, I think we were both really happy with that, but in retrospect, neither of us knew much about preeclampsia, and he had been given the same information as me, that once you deliver, the risk is over, and or that was at least the message as we heard it.
Yeah.
And so it wasn't on his radar either to continue to kind of push at that or dig deeper.
Yeah, Leah, you've talked a lot about just your husband was a mess.
Yeah.
What did he talk a little bit about what that looked like and what he could have used?
So we didn't do as an extensive of a birthing class, but we went to one, and I mean, he thought the most was going to be, he's going to have to put on scrubs, which he practiced, and, you know, be there for the C-section. But he even said, nobody told me that I could lose everything in a matter of minutes. And my husband was, he was supposed to be the support person, but he was anything but, because he was so traumatized. And it took me quite a few years to realize that that was a situation, because of course I'm like, well, why didn't you do this? And why didn't you say that? And, you know, I had all these what ifs and why you should have done this. And then he finally said, he goes, Leah, I was told to say our prayers because we don't know what's going to happen to you. And I was told that we don't know if your daughter is going to make it. So how would you respond when these doctors are coming in and asking questions? My parents actually had to be the ones that kind of answered most of the questions. They had to be the ones that were, they'd never left my husband out, but my dad had to come to Jesus talk with him and pulled him aside and said, I know this sounds very stereotypical, I guess you can say, but you have to man up right now. You need to be the man. You need to be her husband. We understand something traumatic is happening, but at the same time, you still have 2 babies. There's still one living child that we know is okay, but you have to make these decisions. We cannot make them for you. You are her partner. And so my parents were extremely supportive in that, but my parents are the ones that had to round up and finally kind of spoke very abrasively to the medical staff and said, there needs to be a meeting between all her specialty doctors because there was just too much. I know this, I know this, I know this. So luckily my husband had my parents, but they were also going through their own trauma, seeing their daughter. Mm-hmm. Almost, so it really was a hot mess. I don't know how that could be improved. Obviously I was in a coma for about 10 days, so I was out of it for quite a while. So I don't know how that could have been helpful. I do see now maybe having an advocate, a doula, a midwife, somebody there to kind of help and be the speaker for him. We did talk, if we ever decide to do this, we need to have somebody else there. But once I had the kids and once everything was done, he was kind of pushed to the wayside, like, you don't have anything to do with this. And he had a huge role in it.
Certainly when you got home and everything that happened. In a perfect world or in a better world, what would either of you recommend for the follow-up care, the engagement with your spouses, kind of blue sky, I call it blue sky, like what if, what could happen? Could either of you talk to some of those ideas that you've had?
I think now that telemedicine is a lot more popular, I think that would have been extremely helpful, having a meeting. Don't need to leave our home, you and your partner. I know that's not always feasible because somebody's got to work, or sometimes the mother has to go right back to work. So something where both the partners can be there. And I mean, nowadays we have apps for everything. Why is there not something that's coming to us from the medical provider or the doctor's office that's like, have you discussed this? Here are some questions you and your partner can talk about. Because we were just completely lost trying to live, and also anyone that's had a baby, you're delirious and you're exhausted and you don't know what's going on and you don't know why this child is screaming the whole time, and there's just so much going on being a new parent. It's like there's so much information, there's so many books out there, but nothing that talks about kind of these things. If there was like someone, maybe a dad that wrote a, bro, you need to know this book or something, that's like here are some questions to talk about and things to consider, because you don't think that these things are going to happen to you.
Melissa, you've done a lot of thinking about what you've learned after the fact. If you could rewind the clock, like what was missing for you postpartum?
I think one thing is just more explicit discussion at the hospital of, because you had preeclampsia, here's what we're monitoring, here's what we're thinking about, here's what you should be thinking about. Looking back, I can't say, I've only ever had 2 pregnancies and I had preeclampsia with both of them. So I can't say whether my experience was different because of that, but it wasn't verbalized to me, at least in a memorable way, of like, here's the decision tree we have because of your preeclampsia diagnosis. So that's one thing, is just sort of more explicit discussion of what's being done and why, or what the medical team is thinking about, what I should be thinking about. And then the other thing is just the follow-up postpartum, which seems like something the OB practice would ideally have taken care of before I even went in to deliver. Is like, okay, so we're inducing you on X day. Let's go ahead and schedule your appointment for X day afterwards. But I heard several of you talking about the hospital staff potentially being involved in that appointment setting, or even the appointment being at the hospital. All of that I think could be really helpful too. And telemedicine is another big plus one from me, and maybe an advantage coming out of the COVID era, but just if there is some way to have an appointment without having to figure out how to get your 3-day-old into the car seat once again and drive somewhere, and all of that, if there's like a home blood pressure cuff where you take a reading on an appointment with someone, I think that could be a game changer.
How many of you all are actually using any kind of remote blood pressure monitoring, or just remote telehealth? Anybody doing anything about in that realm? No. Wow. Okay. That might be an opportunity, for sure. So, mental health resources, like all of this has obviously weighed on you all to the point where you're like, hey, I have a story to tell. I feel like I can contribute to this work. This has obviously affected you, I guess is what I'm saying. This isn't more than a blip on the screen of your lives. What kind of support did you get in the mental health realm, or did you seek out, or would you have liked?
So as you heard, we had a lot of complications. My daughter was born with cerebral palsy, and anyone that's a mother can probably attest. My child comes first. She had therapy every day, so trying to get myself to physical therapy or mental health was just not a thing. I was completely done. I was exhausted taking her to her appointments and trying to just figure out her whole thing. It took me 2 years before I decided to take care of my own health. One, because I think I was just in this funk, culturally speaking. You get up and you just keep moving on. Like, you're the woman, you're strong, a Hispanic woman, we don't have these issues, and you don't need to talk about it, pray about it. So all these things that I have had for years and years and years stuck with me, and so I would kind of talk about it, but I realized, and I had finally shared with my husband, that there were times where I remember, because now I have multiple doctors to visit. I am now a diabetic, which is a very expensive disease to have in America, but I just felt like I was a medical burden. And I told my husband that there were times where I remember driving on the highway on Mopac and thinking, or on 360, if I just let my wheel go, because there's an 18-wheeler coming, and if this would make things so much easier for my husband. And it took me a few months to open up and say that. I mean, I never did anything of that, but those were the thoughts that I would have, because I just felt like I am now, for the rest of my life, a medical burden to my family. And when I started opening up about that, he was like, I had no idea you felt that way. Maybe we should actually look into it. And it was really hard. It's really hard to find a therapist nowadays. But I remember going to my OB, and she gave, like, it was just a card. Like, oh, here you go. You should reach out to them, knowing that we get busy. We're new moms. We're busy with life, and then you just forget. Like, I just forget most of the time. I have good intentions. I mean, I have a stack of business cards of people I should have followed up with other things, and I just never did. And so it just kept getting pushed off until finally I knew, like, I need to make a change, because I'm not going to be the mom that I want to be if I'm just sitting here in my depressed state and I don't know what to do. Like, I was neglecting my children. My marriage was suffering. There was just a lot of things that made me realize, like, I actually need to take care of myself.
I was very fortunate that our pediatrician checked on me regularly when we would go in for appointments. I'm going to tear up because I think it's probably unusual, and I feel so lucky that that was the case. But like I said, it wasn't really on my radar that the severity of preeclampsia, or that it could have continued impacts in my life. Until after my second, she made a comment about, like, wow, 2 preeclampsia experiences, that must be a lot for you to process. And I was like, I mean, I guess, in the way that having 2 babies is a lot to process. And then as I sort of reflected on that comment later, that's sort of what started my path of research and understanding sort of the long-term risks and the lack of information available seemingly to my providers, my OB, my primary care physician, these doctors that I think are supposed to, or at least I figured would have this interest top of mind, and didn't seem to.
Sure. I want to leave time for some questions, but I also, as we heard everyone introducing their hospitals and what they're looking for, there was definitely a common theme through a lot of you all, that you recognize the power of integrating lived experience on your teams and in your QI work. But a lot of people are kind of head scratching, like, how do I do that? What does that look like? Where do I find these patients? Just off the top of your heads, can you react a little bit to the questions that some of the hospital teams have? Like, how could you see yourselves, or what recommendations would you have for them for how to integrate people like yourselves who have committed to helping, right? You're not just here for your own, like, this isn't like a mental health checkbox, like, let me go do this talk and I'm going to be better. Like, you're clearly committed to improving this for other people. What suggestions might you have?
I think working with, like, OB practices, maybe pediatrician practices, doulas, the kinds of providers that patients are likely to have long-term ongoing relationships with could be one way to sort of tap into that. Like, I don't know that I would have been paying attention if the hospital where I delivered had reached out to me sometime later to seek feedback, or, you know, I don't know what that looks like, but I didn't feel like I had sort of a one-to-one relationship with anybody at that setting. I think I would have been more likely to engage with, like, my doctor or my doula, or, you know, somebody in that sort of role.
So for you, relationship is what would have pulled you into the engagement.
Yeah, I think so.
How about you, Leah?
I feel the same if there was a relationship with, most of us have a relationship with our OB. If there's a way to pull from that. Also, we know social media is huge and people are using that as a way to share. Sometimes it's not always helpful and a positive sharing, but if they realize, like, you can actually use your story because I see you tagged our hospital or you tagged our city, I think, or even with the mental health providers, like partnering with them and figuring out, because there is a time and a space, because there are women that will come in and think they want to share and then they're not ready and realize that either has brought up that anger, and the anger is not going to make change. It's just going to be kind of a vent session. And some that it re-triggers women, or even the dads. Like, I think asking if that relationship is there, then it's easier to ask, have you ever considered, sharing your story and being sharing your story with my clinic. So it's close. Yes, I'd like to share the experience that went on, or maybe with another clinic because they don't want to see the staff that was there. I think just asking from the very beginning, I was very big into social media and my business was online, and so I had a social presence, but I knew the second I got out of the hospital the first time, I didn't know. I look at the videos now and sometimes I'm like, I should have not done that. But it started that spark. I started getting comments of women saying, I had that and I had no idea. I went through that, and most of these people are really close friends that I had no idea that they suffered through these things. Thank you for sharing. And so just starting that journey on sharing my story online is where kind of it started, and that's actually what trickled most of my advocacy work, because I would comment on other news articles, and then people would reach out to me and say, hey, can we talk to you about this? Can we use you for this piece? And so on. And I realized, like, there's an opportunity for me to actually speak on a bigger level and make impact and make change, because it wasn't for me. Like, as a Christian woman, like, God told me I needed to share this because I needed to make an impact. And to this day, my son, the other day my son said, I don't want my wife, my kids are only 7, but my son said, I don't want my wife to have kids because I don't want her to go through what you went through. And I was kind of like, well, what? And so I explained that when I come and do these events, that I'm doing something so that way his sister and his wife, if he gets married or whatever, doesn't have something like this. That was extremely impactful. Like, that was like, because at a point you feel like you're just beating a dead horse. You're saying the same story, you're saying the same thing, and sometimes you don't see change, or you see statistics and you're like, nothing is happening. And then you hear something like that and realize this is bigger than me. So I think that relationship is going to be the biggest one, just like Melissa said.
What kind of questions do you all have? We've got a few minutes left, and I definitely we've got a mic, we'll run it around to you. If you have any questions about anything you've heard, or if you haven't, just about this whole idea of listening to stories and understanding them. This is unusual. Usually I've got up over here in the front. Got a mic coming to you.
So my question is, when you did finally seek out mental health expert, were you able to find somebody who was specific to postpartum or maternity care that specialized in that? Or was it just a general practice?
No. When I did reach out, they were all booked for a year. It didn't work with my insurance. Everything was out of pocket. And at that point, I was like, I can't pay $500 a session or whatever it was. It was extremely hard. So I did have certain credentials that I wanted, but it was not easy to find one. So when I did decide, it took me a long time to find one.
Thank you.
One of the things that I failed to mention at the beginning, but both of these women have been through our Mama's Voices training program, and you heard Leah mention this in passing. One of the things that's really important as you think about who could we work with, do we have any patients that have been through our hospital? There's a couple different ways to look at this. One is all patients are not necessarily ready to do this work. There's an emotional process you have to go through, and and the intent of their engagement matters. And so one of the reasons that Melissa and Leah are here today is because they've gone through our certification process. That process, frankly, it weeds out people who aren't ready or who aren't there for the right reasons. And it is important that you work with patients who are there for the right reasons, right? We don't need people coming with pitchforks and anger and, vendettas. The second piece is, sorry, is there a question back here? Oh, awesome, okay. We don't need to hear from Eleni. Let's hear your question.
Hi, ladies. Whoa. I do some childbirth education classes for our hospital, and I touch on preeclampsia. They usually take the class between 32 and 36 weeks. Usually at the time, nobody has any health complications that they're, like preeclampsia at that time. So my question is, if you had had a childbirth class that talked on preeclampsia and went into detail about it, would it have maybe unnecessarily scared you early on? Or is it something you would have rather have heard from your provider's office or from a childbirth class early?
I actually love that idea. I think that would have been really helpful because at that stage of pregnancy, I was into learning all the things and preparing and highlighting so that I could come back to it later. So I actually love that as a time and a place to reach someone when they do still have the capacity to take on new information. I think that's a great idea.
I 100% agree. I think looking back now, I wish there was even just a pamphlet that's with pictures that they have at the Preeclampsia Foundation. These signs and symptoms, bring them up to your doctor. It is very important that we know these. And I think building that relationship with your patient beforehand will make a big difference that they'll want to share with you. But I know a lot of women will say, I don't want to hear the bad. Well, honey, you need to hear the bad because you need to know what to look for because you want to be here to be with your baby and your baby to be here to be with you.
And I will just say from an evidence-based perspective, there actually is a lot of evidence in the literature that it does not increase anxiety, it actually reduces anxiety. And what we also know, both anecdotally as well as what the literature has shown, is that the bigger the delta between your expectations and your reality, the more mental health trauma there is from the outcome of that. And I would just challenge all of you to go, if you get on a plane and they do your safety briefing, do you all of a sudden go, oh crap, we might crash? No, but you know some things to just be on the alert for. One last question, and then I know we're out of time.
You said that you were dismissed at least twice. What words did you use? What did you tell the provider? What were you trying to express to them? How could we hear you better?
I did tell, so we noticed that baby B did not grow at all from the last visit, and I was doing pretty frequent visits, and she was like, oh, okay, well, maybe we'll see you on the next one. I said, well, while we're talking, I have these signs and symptoms. Or upper right quadrant pain. I said, I'm not eating at all. I have really bad indigestion. So very similar to common pregnancy woes. I said, my swelling is immense. I wake up swollen, I go to sleep. There's no time where I'm deflated. I said, I just feel awful, my head. There were all these things. I felt sick, I was sleeping all day. And she goes, that's normal pregnancy, you're carrying two. I said, okay, well, everybody said I should feel really bad for carrying twins. So you must know what you're talking about. And I didn't make it back to that visit. I think it was a week later.
Question in the back here.
So y'all mentioned that y'all would have liked to have follow-up calls. At my current department, we do follow-up calls about a week later after discharge, but we kind of have a script that the techs follow when they're asking questions. They're asking if you're breastfeeding. They might check up on mental health. How many follow-up calls would you feel like would not be annoying to you?
I mean, I've worked in a lot of businesses where you basically keep following up until they say, leave me alone.
Yeah, I think if it got annoying, I would maybe stop answering, but I don't know that there's like a too much there. But at the same time, if there is an existing script that could get like modified, like, oh, and if this person had X complication, here's this question to ask as well. That could be a way to do it kind of all in one.
Do you feel like if there was a text option, that would probably be the best, where you could reply at any time?
I would say yes. Just as a new mom, you're busy, you forget. I still get texts and I think I answered and then I'm like, oh, I didn't do that. So if you have that reminders with cute little emojis, I think that would kind of, just something light and like we want to talk to, or whatever the question may be, and then here's for more.
I know you're looking for a very standardized process for doing that follow-up, but I just want to emphasize some level of customization has to be there to acknowledge that particular patient's experience. I mean, this isn't about my story, but I lost my daughter at birth because of preeclampsia, and some of the hardest things to deal with was, like the diaper coupon coming in the mail later, or all my milk that still came in, and the lack of recognition of that, the lack of acknowledgement of that in a follow-up phone call about my health would have been really traumatizing. So I think some acknowledgement of like, here's a quick snapshot of this patient profile, this is what she experienced, now let's do that follow-up call. Not just with the standard, you need to get your blood pressure checked, blah, 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 blah. Because that mental health piece of like, what is she going through has to be part of that, I think.
Hey y'all, we've talked about implementing a program that does automatic consults for high-risk deliveries or high-risk pregnancies in the hospital. And I'm wondering if you mentioned a social worker saw you, but I'm wondering if you had a provider, mental health provider, or social work automatically come in and talk to you in the hospital, would that have been one more thing to deal with, or would that have been helpful?
I think that would have been helpful because at least they would start building that base and maybe taking that to my partner and saying, hey, these are some signs and symptoms we're noticing, or maybe you need to, because obviously I don't think they could have, they might have been able to talk to me, but I was kind of out of it. So I think that could give an opportunity to reel in that partner or the parents or whoever is there, the supporting people, to say, these are some things. And then at least it's on the chart so the OB can follow up and make sure that things are progressing in the right way instead of just being ignored.
So I just have a quick question. So Lee, I've heard your story before, just a month ago when you were in Waco at the coalition meeting, and something you brought up along the lines of kind of being dismissed by the providers was that you established a great rapport and had a good trusting relationship with your provider, but then the on-call physician, I think that was covering when you actually delivered, and the MFM is kind of where you feel like there were gaps in communication. So I think just as healthcare professionals, how do you feel we could, I guess, close that gap and just to ensure that all the providers and the entire team is communicating? Because I think you had mentioned, like when you spoke in Waco, that that's where you feel like
So I know what you're talking about. So I didn't share that in this one, but when I was initially, my doctor thought my platelets were dropping, but nothing was a red flag, or nothing was dangerous, but it was kind of like a little red flag. We need to start watching. And it was Christmas break. My OB wanted to check my blood pressure, and she said, I want to make sure you're okay because I'm going on vacation. Not what she wanted to be doing and not what I wanted. But in my head, I'm still like, nobody's ever told me that bad things happen. It's only to unhealthy people who don't eat right and don't exercise. I'm good. I've gone to all the visits. I've done everything right. And so I was passed off to the partner because she went on vacation. I was coming in now every day to get my blood pressure checked. So a blood pressure cuff home would have been fine, but they were like, can you go buy one? And at that point, I was like, we've already dished out so much money. And it's Christmas. That's another thing. I should be fine. I came in, and the partner saw me, and my blood pressure, which was what she was seeing, was normal, but my base is low. So my OB already knew hers is raising. It's not at the 140 over 90, but it is high for her. So we need to monitor. And she was like, your blood pressure looks great. Go enjoy your Christmas break. And then that was kind of where I was sent off with that situation. So I think a summary, I mean, I think I heard that, like, being on the same page. I mean, even in the same office, they weren't on the same page. She didn't know my history. So I looked like a normal patient to her, but if she knew my history, or maybe if that was like a big sticky note, like has low blood pressure, monitor XYZ, then that would have been a red flag for her.
All right, well, I know we need to close up and move on to the next segment in our learning session, but Leah and Melissa will be here. Feel free to approach them with any other thoughts or ideas or suggestions. Don't be surprised if all of us show up in SIM training and provide our 2 cents worth about the patient part of that experience. Any other closing thoughts? Just like 30 seconds of like, this is really something I wanted to communicate that I don't know if I got it out. So if both of you could hit your 30-second closing remark here.
I don't know if there's anything I didn't communicate that I wish I got out. I guess one thing that stands out to me that I sort of already touched on is just the degree to which I represent sort of the best case scenario, both in terms of like the lack of complexity of my situation, but also like I'm a highly resourced, highly educated white lady with a supportive spouse. So just knowing that like these gaps existed for me, they would be magnified for lots of patients, I assume. So I'm excited to see that that's a big part of the focus here today too.
I think just you all being here is a huge step forward. I liked hearing the asks because it means that we all have areas for improvement. I even see in my own care where there are things that I could have done differently or better to possibly create a better outcome. I think just recognizing that we are people just like you, if you kind of put every patient and thought of it as your daughter, your sister. I know sometimes it's quantity over quality. You have to see a lot of patients, and that is way beyond anything you can change, but remembering that we are people too, and sometimes we don't know what we don't know, and I think educating us as we're going, or letting us know, reassuring, or us or the partners, because there's a lot of medical jargon happening, and we're like, we don't know, we freak out, and then kind of being shushed because we don't understand. But let us understand so that way we can maybe give some feedback or input or make a difference. And I think if it doesn't happen there, then something like this, in the end, the partner or the patient can make a difference and say, this is where I could have done X, Y, Z, or I could have told you, yes, I had this pain, but you were assuming I had this here. So thank y'all for listening to our stories.
Yeah, thank you.
Can we give Leah and Melissa a round of applause? Thank you.
Thanks so much, Eleni, Leah, Melissa. We have a break now, and it will end at 10:15. So we're going to change the slide, but 10:15. Be back here.